You are listening to Single Payer Radio. This is Kay Tillow. I'm with Kentuckians for Single Payer Healthcare, and this program is coming to you on WFMP LP 106.5 FM on your dial. You can listen to our show here on Mondays at 2 p.m., on Tuesdays at 7 a.m., and on Wednesdays at 11 a.m. And I'm delighted to bring to you a special guest today. She is a physician. She resides in Pittsburgh, Pennsylvania, and her name is Judy Albert. And I'm going to let her tell you a little bit about herself.
Well, good morning, and thank you, Kay, for inviting me to be on the show. I've never been on a radio program before, so it's exciting. So I was trained as an obstetrician gynecologist, and then I did subspecialty training in reproductive endocrinology and infertility, and spent 30 years in mostly private practice, but for some time I was in an academic practice, both at the University of Pennsylvania and then at University of Pittsburgh. And most of the care that we delivered was unreimbursed care for patients who have infertility, because private insurance companies can decide that, have decided that infertility is not medically, does not meet the criteria for being medically necessary, at least the treatment for it. So the diagnosis of infertility can be made, but once it's made, insurance backs away and says treatment is not medically necessary and is unreimbursed. So, I spent, and that varies state by state, but in my state, there was no mandate that treatments needed to be paid for. So some insurance companies that are employer-based have offered that type of coverage, but the vast majority did not. And so I did spend quite a lot of time as a practitioner trying to negotiate the waters between when is the diagnosis of infertility made, so that everything else that you do for that patient is then in the no covered category. And also watching patients struggle to achieve their goals of having a baby by mortgaging their homes, having multiple jobs. And it was Pittsburgh is not a place where there is incredible Silicon Valley type wealth, and so it's heartbreaking to watch people go through that. Over the years, there were some employers, as we saw some of the high-tech employers move into our area, and for instance, Facebook and Google both have offices now in Pittsburgh, and they developed a consortium of insurance riders that they offered to all of their employees that gave unbelievable coverage for infertility care. And this is an attraction that those companies hold out to their employees who are asked to work crazy hours and devote their lives to the strategies that those companies are trying to pursue. So we did see that there were some breaks in the system, and some people were getting coverage. So that's a background of what happens when insurance is not covering services. It's not quite the same as when you're poor and can't access any services for life-saving care, but it certainly set the stage for my thoughts about healthcare. And as I came towards the end of my career, I had been in private practice the last 20 years with another woman, and we had also the experience of being employers and having to provide insurance for our staff. We had a staff of about 28 individuals that worked in our lab, and ultrasonographers and nurses and administrators and billing staff, and we were committed to providing healthcare and a pension plan, and actually we were completely female run and staffed, except for one man, practice. And so we saw the other side of every year negotiating how much we were going to pay in order to insure our staff. And we also, knew that medical practices don't run on a large profit margin, at least ours didn't, and that at some point we were going to need to retire because we were getting older. So at the end of 2018, we successfully negotiated a sale of our practice at the University of Pittsburgh, and then we became employees of the University of Pittsburgh, and I just really couldn't tolerate practicing in this corporate style of medicine, and that led to my retirement at the end of 2019.
What was wrong at the University of Pittsburgh when you were practicing?
At the university?
Yes.
Well, let's see. What wasn't wrong? There were a lot of promises made that weren't kept, which is typical. And, I was kind of naive. I'm sure every person in business can relate to the fact that when mergers happen, that the whole flavor of an organization changes. But most prominently, the things that we saw were they, as I said, with watching patients have to pay out of pocket for services that in many cases would normally be covered, such as ultrasounds. They raised the prices on all of our procedures, and it just because they could. And that when you raise prices and you do have some of it covered by insurance, the people who have the insurance coverage aren't going to suffer, nor are you really going to get a higher rate of reimbursement because the insurance decides what's the usual, customary, and reasonable price to pay. But who it hurts is the people that don't have insurance because you can't discount them. So we used to charge, say, $200 for an ultrasound. They raised it to $500. So our non-insured patients are paying literally more than double for a service that they still had to pay for, but it was less costly. And all the insurance, they were going to make all their extra money off of these people that didn't have insurance. So that was just the tip of the iceberg. And they already are a multi-billion-dollar corporation, University of Pittsburgh Medical Center. And so it didn't really seem like that was the right way to go.
That's a terrible thing.
Mm-hmm.
So how long have you been involved in Physicians for a National Health Program? How did this come about?
Well, I had been interested in some ways of looking at oppression and social justice. I would say a lot of it was because of the actions of one of my kids. My middle son has had a real strong motivation to be involved in social justice organizations, environmentalism, and more recently, anti-racist organizations. And I had gotten involved in some of those with some very much younger people who were doing grassroots teaching and organizing in like 2014. And in 2016, around the time of the election, I was feeling like there must be a way that I could sort of join together maybe my experience in medicine and some of those activities. And I can't actually remember how I found out about PNHP, but I did, and I looked at the website, and the contact person for Pittsburgh was Dr. Anna Malinow, who was a former president of PNHP. I never met her before, but she was just sort of reactivating a group of physicians. And I started going to those meetings, and Anna is an incredibly knowledgeable and motivating person. And we, got a official charter going for sort of a new chapter. There had been chapters there before, and that's how I got involved. And then sadly, she and her husband moved to brighter opportunities and work to San Francisco. And so I was left with a small handful of other people to try to carry on our mission.
And you're now the president of the Western
Well,
Pennsylvania?
we don't really have, I mean, we're pretty small, and there are really literally only a handful of people. So we kind of call ourselves co-founders, and we have never really set up a structure of officers. So I really wouldn't call myself the president.
So you have a collective leadership, and you are one of the contact people to make that go. Well, yeah. I'm aware that you've done some good work to try to reach out to union locals, and to workers who have been on strike, and to workers who are trying to negotiate contracts. And I really appreciate that work that you've participated in, trying to make sure that people in those situations have the information that they need to fight for the kind of plan that would really end this terrible struggle that unions have to bargain a new contract every few years, with the prices going up and the situation eating up the money that they need to put into wages and other benefits. So
yes, that's been another super important contact, which Anna had really forged with the Western PA Coalition for Single Payer, that Ed Gristar has been the, I guess, I don't know if he calls himself president, but they, and I can't even tell you the full on background, but they're a much longer group in existence that have community members, several of whom are connected to the labor movement. Ed's a retired labor organizer, and some labor attorneys that are involved, and they are the ones who connected us with lots of local labor organizations, interestingly, mostly outside of Allegheny County, which is where Pittsburgh is seated, because Allegheny County's labor branches have so many ties to private insurance financially, at least their leaders do. So we've done outreach into areas up to as far north as Erie, and in the surrounding counties to Allegheny County. And we were lucky to have the ability to show a great film that you were involved with, Kay, called Off the Table, that makes the case for labor unions to support single payer, because if they don't have to negotiate for healthcare, then they can negotiate for their stagnant wages to increase. And so we've had a lot of opportunities to show that film at different places, and it gets great response from the rank and file labor. But it's been a huge education for me to try to come to an understanding of how the rank and file and the leadership operate and interact with each other. I still don't understand it, and it seems, you can probably correct me on this, Kay, but it just seems like the politics require an extremely savvy person to navigate that successfully.
Well, I don't know. I've spent my life in the labor movement, and I certainly have not successfully transformed it into into the labor movement that I want to see. But yeah. We did work for a very long time to get local unions and state federations to endorse national single payer healthcare. Mm-hmm. And I think that we got, I think, over 600 union organizations to endorse HR 676, which was the national single payer bill. And I still think that project is worthwhile, to bring labor on board at the grassroots and to keep pushing things at the top. At the top of the labor movement, it's kind of a dual position. Therefore, single payer someday, but for right now, they really tend to just follow what the mainstream part of the Democratic Party says, which is to improve the Affordable Care Act. So that's still a project that's underway, is to, if we could move all of labor to push for single payer at the national level and to condemn the efforts to keep us strapped into the Affordable Care Act, which keeps the private insurers in the mix, we would have accomplished something big, but that's yet to be done. It's on the agenda.
Yeah.
So I know that you are one of the people who organized a recent educational webinar, it's called, on direct contracting entities. So that term is not familiar, I'm certain, to most people. So perhaps you could tell us what that is about and tell us about that event.
Sure, I will try to explain it. It's very, the webinar, putting the webinar together wasn't that complicated, but the subject is very complicated. So a few of us who had come together nationally, I mean, and this has been the beauty of, if there is any sort of positive about COVID, is that I feel like we've been more connected to people outside of our local areas who are active in the single payer movement through Zoom, and it's become commonplace to have meetings with people from all over the place. So some of the people who had been talking in other groups had become aware, largely through the efforts of a health journalism journalist, Trudy Lieberman, was how I first heard about the direct contracting entities, that there is a new plan or model that the Centers for Medicare and Medicaid Innovation came up with to further the goal of that organization, the Centers for, I think it's actually Centers for Medicaid and Medicare Innovation, which is housed in the center in CMS, and their assignment is to develop new models that would save money for Medicare, for the Medicare system, while improving care, or at least not reducing the quality of care. And so one of they've developed a number of models over the years. That CMMI was created under the Affordable Care Act. And so since that time, they have developed models towards this goal of trying to reduce costs and maintaining the quality of care. And largely those have been models that involved accountable care organizations, which are organizations that feature the use of quality measurements. So there's several metrics that they set up, lots and lots of metrics, to determine that physicians are doing the right thing and patients are getting the right tests and the right treatments for certain diseases. And if they do that, then they will be rewarded in some way financially. It's much more complicated than that, but that's a quick overview. And so through the years, some of the ACO models hadn't maybe been performing as well as people hoped, and so they are forever creating new models. And this new model of direct contracting entities uses a similar approach, but the difference is that traditional Medicare beneficiaries, those that signed up for fee-for-service traditional Medicare, could be enrolled in a direct contracting entity without their knowledge. So the other piece of this that I didn't mention is that Medicare Advantage has been another tool that CMS has used to try to save money by allowing the entrance of private insurers into the Medicare market. And that precedes the Accountable Care Act by many years. Medicare Advantage plans have been around since I think the 80s, but they've taken up an ever greater share of the market, such that now 40% of Medicare beneficiaries are enrolled in Medicare Advantage. And so Medicare Advantage is a choice that beneficiaries can make when they turn 65. That is a way of assuring that they don't have gaps in coverage that traditional Medicare has, because traditional Medicare is an 80-20 proposition. So meaning that beneficiaries are responsible for 20% of the coverage. And the other route to cover your gaps is to get a Medigap plan, which is a fee-for-service type plan.
Wow.
All of that is just ridiculously complicated. So the DCEs were just are a group of entities that mostly involve accountable care organizations, which are organizations of physicians that work within their networks with primary care doctors and specialists to keep costs down. And they are paid in a capitated sort of way, meaning they get paid up front, and they have a certain amount of money to use to take care of their insured beneficiaries. But if there are more needs that group has, they're going to be penalized in some way if more services are required than their capitated fees pay. So all of that has the potential to lead to skimping on care for patients. And the direct contracting entities are on multiple levels trying to help figure out what population of patients are going to be the best to insure, meaning, probably figuring out healthier ones, and also figuring out how they can use billing codes and diagnosis codes to improve the reimbursement, which is another whole. So now I think I've probably completely confused everybody about that.
Well,
But
I appreciate the attempt to straighten us out. So we have Medicare is the program that is for those 65 and older, and for some people who are totally disabled, right?
Yep.
And for, I think, some people who have end-stage renal disease and need dialysis.
Right.
So it's a big program, and this was established back in 1965 under Lyndon Johnson, and it's been a successful program. So what you're saying is that when they passed the Affordable Care Act in 2010, they put in there this section on the Center for Medicare and Medicaid Innovation, and it's under that program, which is a part of the federal government, that these direct contracting entities are being experimented with.
Correct.
Can you explain what that, I see that I think Anna Malino came up with this, that the direct contracting entities were a Wall Street takeover of Medicare.
Right.
How exactly is that working?
Well, so maybe backing up a little bit and talking about how the Medicare Advantage model has sort of shown a light for Wall Street on how profits can be made in the system, and then how DCEs can also factor into that. So when the federal government decided that, well, maybe we have this system from 1965, it's working pretty well, but for whatever reason we still think that private corporations can do it better than the government, and so we want to let in some private insurers, and probably there was some pressure from lobbyists and so forth, and so they let in the private insurers to write these Medicare Advantage plans. And in the Medicare Advantage system, there is also a sort of capitation where the insurance company, whether it's United or Aetna, who's your Medicare Advantage provider or insurer, is paid or pays the physician a certain amount of money to deliver the care, and they can increase the amount of money, and they're paid this money. The Medicare Advantage private insurers are paid then by the government from the Medicare fund to then pay the providers. So they function as a middleman. And what Medicare has allowed to happen is that the payment, the per patient per month payment for Medicare Advantage from CMS can be determined based on the level of that patient's complexity in terms of their medical problems. And in turn, there have been schemes developed to increase the level of complexity and therefore the payment from CMS to the Medicare Advantage plan by upcoding. And by upcoding, what we mean is that somebody with diabetes could be coded as just a diabetic code when the doctor puts their information on the billing sheet. But they also could be upcoded by adding the fact that they have several complications from diabetes, and maybe the doctor isn't fully realizing that they need to put all those different codes in. But if they do, the reimbursement from the government will increase. And so other loopholes have developed to allow the Medicare Advantage insurance companies to go through patient records, through electronic record system, and do the upcoding themselves, kind of over and above the physician. And they've even allowed for Medicare Advantage and the insurers to send nurses into beneficiaries' homes and ask them questions that allow them to increase the value, basically, of caring for that patient, because they're going to get more money from Medicare to do that. So as a result, Medicare Advantage insurers, like your large corporations, have made lots and lots of money. And in some cases, they've been found to be committing Medicare fraud. But what that looks like to Wall Street is a place that more profits can be gained, and by theoretically forming additional middlemen who can help various organizations of physicians and hospitals to figure out how they can increase their capitated fees, and maybe they help them also to cut their expenses in certain ways and cut corners in various ways that they deliver care. And following the model of venture capital, which is you invest quickly in a accountable care organization, which is a group of physicians and hospitals and so forth. You figure out how to, in rapid time frame, increase their profits, which you can do by changing the reimbursement coding, by cutting corners, by getting a better supplier of medical devices or drapes or whatever. And then once the profit is made, then the venture capitalist exits, makes their profit, and the organization may be left significantly diminished from what they were before. And that's my understanding of how Wall Street might enter. And so who's left at the end of the day holding the bag is, some physician providers that may or may not still have an organization that they're going to get paid for seeing patients with, and also the patients on whose backs these cuts were made. And furthermore, the big problem with the DCE model is that it was very unclear in the description by CMS and CMMI that anybody signing up for Medicare would have any control over whether they were put into one of these DCEs. So it raises so many alarm bells for how complexity confuses and masks things that are happening that aren't creating benefits for patients. And when people try to understand it and they can't understand it, they throw up their hands and walk away. And that's actually part of the plan, is to make the policies ever more complex so that you can't sort through and really see, well, what would be cost effective and what would be care effective to get better health outcomes for patients in this country.
So when we're in a period of enrollment now in Medicare Advantage, right?
And Medicare in general, yeah.
Right. We see ads everywhere you turn, Joe Namath and JJ Walker. And I saw someone else who was familiar. Oh, Joe Montana, lots of sports figures.
Right.
Are advertising on TV. And of course, those ads must cost a fortune, which is, I think, gives us some indication of how lucrative it is to sell these Medicare Advantage plans to the population. So why is Medicare Advantage growing so large, getting such a big cut of Medicare, when really traditional Medicare has the advantage of not having so many denials of care, not so many pre-authorizations, not limited to a network where people in traditional Medicare get to see the physician of their choice. So why does Medicare Advantage grow?
Primarily because they're offering very discounted rates to the Medicare beneficiaries. So many times, and this is ever increasing, there are no premiums for Medicare Advantage. So even though, we think that Medicare is supposed to be free when we turn 65, it's not, because you pay a premium that's, somewhat based on your earnings through your lifetime, and you pay an additional premium to get a Medigap plan, which, most of us in the 65-year-old age group would feel is necessary, when we do get sick, to cover the things that Medicare doesn't. And so those premiums can actually, be quite high. And to get a Medicare Advantage plan that has no premiums is a huge draw. And then there are other perks that have been added on to make them seem more attractive. And sometimes it's a dental benefit, but usually the dental benefits that they add in a Medicare Advantage plan are very small. Sometimes it's, you'll get free Meals on Wheels, but again, after you come home from a hospital stay, you'll have Meals on Wheels available to you, but it might last for a week or two, and then that benefit goes away. So there's a lot of bells and whistles that are offered. Oh, gym memberships are another big one.
Right.
Silver sneakers and things like that. But the problem, as you said, is that the biggest problem is that Medicare Advantage operates in narrow networks. So if you happen to get sick when you are not in the geographical area of your narrow networks, and most of these networks are very circumscribed in a geographical area. For instance, in Pittsburgh, we really have two healthcare systems that we can use. And so if somebody happened to be in Kentucky and had an accident, they are at risk of not having a provider in their Medicare Advantage network that they can go to, or they get sick or have a heart attack when they're traveling somewhere. So that's a huge disadvantage. And then, more commonly, the narrow networks are going to function in such a way that if you have a problem that requires a specialist and the best one in your area is not in your narrow network, then you're not going to be able to go to that person and have that care covered. And so people within Medicare Advantage who start to get sick, which I mean happens to us all as we age, are finding problems with the narrow networks, and sometimes the expenses with their copays outside of network payments and so forth become just unsustainable, and they would want to drop out of their Medicare Advantage plan and go back to the traditional fee-for-service Medicare, which is portable and you can use it everywhere. And all specialists are included, and virtually all specialists would participate. I mean, pediatricians not so much because they care for babies and kids, but people that take care of adults are going to participate. So that is a huge disadvantage to Medicare Advantage.
And we discovered recently that when you try to go back to traditional Medicare, because of these problems encountered in Medicare Advantage, the denials, the pre-authorizations, the narrow networks of both physicians and facilities, rehab, hospitals, et cetera, when you try to go back, the protection from discrimination for pre-existing conditions no longer exists. And except in 4 states, which are all up in the Northeast, people who try to go back to traditional Medicare can be denied a Medigap plan. That's the supplementary plan, or they can be charged more, which is another great disadvantage of going into Medicare Advantage. That is, you lose the ability to take advantage of being able to get, without discrimination, without underwriting, a Medigap policy. So actually, we here in Kentucky have taken on that struggle and introduced into the Kentucky State Legislature a bill that would make us one of the states that doesn't allow that discrimination. And one of the physicians involved in our organization actually got a resolution passed at the Kentucky Medical Association that also took that position, that Kentucky should become one of the states that doesn't allow this discrimination. Anyway, all of that is so very complex, but at least with Medicare Advantage, which is what we have had for some time, there is some choice. In other words, people make a decision to purchase that plan, maybe under false understanding or false advertising, but at least there is some decision that the patient has made to choose that plan. That's not the case with the direct contracting entities. Is that right?
Well, that's what we think. I mean, and again, it's not clear in any of the description in CMMI as to how that would work. And we have heard of subscribers who've received a letter saying, well, you're now part of, your doctor is now part of this ACO, which may be one of the direct contracting entities. And so you're going to sort of get sucked in that way. And before you know it, your care is now, because your doctor, maybe their practice was bought by one of these entities, you won't have a bright white line that shows up on your Medicare card that says, Medicare DCE or anything like that. And so the question about whether you can get out is unclear. And it's my impression that the DCEs are already functioning, but it's, I think, too early to ever get any information about that sort of problem. Are people able to get back into Medicare fee-for-service?
It doesn't look to me like they are. It seems to me that they can do that if they leave their physician and find a
Right,
physician
exactly.
who isn't participating in one of these DCEs. But that's a pretty harsh thing to have to do if you have a relationship
Sure.
with a physician. That's a earth-shattering thing to have to do to get back into a traditional Medicare plan. So, well, wouldn't the thing that, well, the person might not notice that they're in the DCE, but their physician would now be paid through capitation, which means the incentive, the monetary incentive to the practice, which may be owned by some private equity, group that makes the decisions rather than the physician. And the incentives would all be to give less care. Is that right?
Right. Yeah, I mean, whenever you pay someone up front and and that's all they're going to get, and there's also another piece of this which is also very complex, which is the shared savings, so that some physicians are going to be rewarded if they if the group as a whole somehow saves money, because they're not billing for as much care, whatever constitutes care, whether it's ordering extra tests or trying a new treatment. Then they will, the providers or doctors or the group that owns the doctors will participate in some of the savings that the insurers gain from their ultimate payments from CMS. And so it does create an incentive for physicians as well to, and there's a great deal of debate about whether this type of, so-called value-based care is really helping anyone. There's debate about whether it's really saving any money, because it costs a great deal of money to implement all the tools to try to figure out if you're saving any money. and also it on the so-called quality side, which is, are patients healthier? Are they living longer? Are diabetics, getting their testing on a certain schedule so that their sugars are in better control, and so on and so on. All of that requires the implementation of infrastructure that measures all of those things, and people are just trying to create that from scratch. There was no template where we can just throw this on and say, well, now we know that the quality was so much better, and now we know that our overhead went down. But it stands to reason, as you pointed out, that the overhead from the insurance companies can't possibly be going down when they're spending millions on these ads. And it is just a massive campaign, I think, this year more than ever, with the TV ads, the mailings. And I just turned 65 this year, so I've been getting all of it. I don't really watch TV, so I haven't seen the luminaries that are the Joe Namath and all of that, but the stuff that's coming in the mail, and I also get a lot of phone calls for Medicare Advantage. So, I guess, to kind of go back to the bird's eye view, the other question is, well, why are we hearing over and over again that, each year the United States comes in last of economically developed countries around the world in terms of our life expectancy and health outcomes? I mean, that must be something that we could look at to understand how we're doing in this effort to improve quality and improve care. And So it's really a difficult situation, and it's so confusing, and totally understandable that people who are on a limited budget, retired, no longer seeing an income, are going to choose a plan that doesn't have a premium, no monthly premium.
Absolutely.
I totally understand that.
Absolutely.
And and the lack of knowledge about it. I was with some friends last night. All of us were physicians, and two of them aren't yet 65, but the other two are past 65, and one is a retired pediatrician, one is an about to retire psychiatrist. And they told me that they signed up for Medicare Advantage, and actually one of that couple is an insulin dependent diabetic. And I was just so afraid for them, and I didn't want to react to. They've already done it. It's already a done deal. And she said, well, there's no premium. And so I it's kind of hard to be the bearer of bad news that you may not ever get back into fee-for-service Medicare. But these are physicians. And he, as a pediatrician, he wouldn't have had any experience with Medicare, from the provider standpoint. So,
well, I don't think that we can defeat these for-profit tigers in our healthcare system by simply encouraging people not to choose Medicare Advantage.
right.
Because,
yeah, no, it's too tempting.
And we have so many of our seniors who live on such limited incomes. We've had a crash in pensions in many industries, and people are not retiring on adequate income. So if they can lower their monthly expenses, I think that is it may be for many people the logical step to take, because if you don't get sick on Medicare Advantage, you can come out better,
right?
On the basis of a monthly cost. If you become very, very ill, then you discover that those copays, deductibles, and limitations enter into causing that to not be a good decision. And of course, for those who see healthcare as a money-making proposition, that's great for them. Then once it gets expensive for you, you want to get out and you want to go back. And that means that they get rid of the people who are more costly, and they reach out for the younger and healthier people to make more money. So we really are faced with a situation where I don't think it can be solved just by encouraging a choice. I think we as a nation have to take on, what are these profit makers doing to our healthcare system? And how do we fix it? What do we have to do to make something better happen for our people?
Well, I mean, every time I go into the rabbit hole of trying to understand, and really parse out the various reports on what are the cost savings that Medicare Advantage or any other of these models like ACO and value-based care and everything, you start reading, and there are conflicting reports, but it's impossible to sort through it and understand it. And I'm always just left with if we didn't have these multitudes of layers of middlemen and methods of accounting and capturing this or that small savings and comparing that to the overhead and everything else, why wouldn't we want to do a single payer? And it's not as if it hasn't been done and implemented and succeeded in other countries. I mean, everybody's well aware of that. As far as the European models, the Canadian models, it just seems so obvious that there are many examples of public plans that do it well, such as the VA, such as traditional fee-for-service Medicare. And, we would do so much better to simplify things. It makes it easier to account for what's going on when you don't have so many different players.
Right. I think one of the problems is that we have the wrong diagnosis by those who run the CMMI. They basically believe, or at least they assert, that the problem is overtreatment.
Right.
That the doctors are giving too much care, people are getting more, that there's an overuse of the system. And I think that's not true. What do you think?
No, I think it's definitely not true.
So what they are treating when they set up these experimental things, these ACOs and direct contracting entities, they're trying to squeeze out that overuse.
Right.
And what I see is that we have more underuse, more people who need care and don't get it.
Absolutely.
And that they're treating the wrong problem, and that we could save the money, we could remove the for-profit insurers from our system, saving massive sums, enough to cover everyone who doesn't have coverage, and to improve coverage to all medically necessary care, dental, eyeglasses, long-term care, everything we need, and do it for no more money than we spend now. What do you think?
Absolutely. And, of course, PNHP has spent years documenting how the money actually adds up. And there's, there's excellent evidence that it wouldn't cost more. And I think I had a few glitches when signing up for Medicare. There's some rule in there that if your birthday falls on the first day of the month, your sign up is different. And I happened to be born on September 1st. And, I got a little frustrated, and I ended up having to go 1 month without my Part B. But it takes effect tomorrow. So I'm fully, but and I was getting all upset and thinking, well, actually the government's doing a terrible job. And then I thought, well, if we didn't have Medicare only at 65 and I had it since I was born, then you wouldn't have any of this. You've got all these pressure points where, you're born and, hopefully your parents have employer-based insurance, healthcare insurance, and you're covered automatically. But then you turn 26 and you can't be on their plan. And then you turn 65 and you have to figure out the enrollment and pick Medicare Advantage. And think of all the simplicity that could occur if it just started at the beginning, and then you didn't have all this stuff about signing up, and you didn't need all the gnashing of teeth over which way you're going to go, and it just makes so much more sense. And that doesn't even get into the issues, as you said, with people not getting the care that they need.
Right.
They're not covered.
It's an extremely complex situation, and we in the single payer movement are working to try to explain to people and to mobilize our nation. It seems to me that almost everyone, not everyone, is for everybody having the care that they need. And that what we don't yet have consensus on is how do we do that?
Right.
And, there are those who say, well, let the market work, a free market, price, get a little competition out there, the prices will come down. And we think that the world has shown us that the systems that work are to publicly fund healthcare and to make it automatic and available to absolutely everyone. And that can bring down the cost and assure that everyone gets the care they need. So we're fighting this privatization of Medicare now because that's been the model plan in our country for our single payer movement for a long time. And these direct contracting entities seem to threaten that solution by handing over Medicare to Wall Street as we're trying to expand Medicare to cover all of the people in our nation. Here in Louisville, one of the direct contracting entities is Humana. So they're one of the big insurers, and they seem to be one of the insurers that's into this big time. We've been talking with Judy Albert. She is a Physicians for National Health Program leader in Western Pennsylvania. She is also a OB-GYN and is working very hard to explain direct contracting entities and to mobilize the public to protest them, to do something about that. You can sign a petition against the direct contracting entities at pnhp.org. If you go to that website, you can find a way to do that. And we appreciate it very much, Judy, that you've been able to be with us. Do you have any parting thoughts for us?
Sign the petition and stay aware of what's going on. Try to get educated about the different changes that are happening as best you can. It's quite difficult, but in addition to the petition available on the website pnhp.org, there is just a treasure trove of good explanations and non-wonkish ways of understanding how we could pay for a single payer system. And I strongly encourage people to utilize that website. It's so much better, and it's all at one place, so much better than trying to find things just by scanning the internet.
Well, thank you so much, Judy, for taking the time to be with us on Single Payer Radio, and we appreciate that very much.
Well, thank you. Thanks for having a single payer radio. That's awesome.